from Germany.
Dear Paul, ladies and gentlemen, dear colleagues, it's a nice idea to speak about the treatment of acute lymphoblastic leukemia, past, present, and future in 15 minutes. This is a period that covers about 50 years. If we step back to the roots, leukemia was described by Rudolf Virchow in the mid of the 19th century. And about 100 years later, the first communication was published about the temporary remissions in acute lymphoblastic leukemia by Sidney Farber. Another important publication was, or detection was, by Oetken that leukemia could be inhibited by L-asparaginase. This was in 1967. Then in the 60s, other drugs were detected and investigated, and it was shown that they had activity against lymphoblastic leukemia. These were the glucocorticoids, the Vinca alkaloids, asparaginase I mentioned already, and also the anthracyclines. And then combinations were used of these drugs, and it could be shown easily that the remission rate was increased by the combination of drugs, and you get a 98% remission rate by the combination of 4 drugs, for instance. And then another main step in the development of ALL treatment was by Donald Pinkel in Memphis, the preventive radiation therapy to the central nervous system, which led to first real cures of acute lymphoblastic leukemia. It could be shown that about 30% of the children would be long-term survivors with this combination treatment, induction therapy, preventive CNS therapy, and maintenance. Many questions have been posed, but first, when I started pediatric oncology, or pediatrics even, there was a textbook by the famous Guido Fanconi in 1972, and he still wrote that prognosis is dismal. Long-term remissions over 5 years are achieved in 1 to 3% of all children with leukemias, and out of these few children, about 50% survive relapse-free for even more than 10 years. So it was clear there was something about it, but nobody knew really what it was. Of course, there were others who had more information already at that time, but the official opinion, more or less, was still leukemia in children is incurable. And then there was a very intensive movement in the treatment. Many questions had been posed, which were, for instance, the choice of the glucocorticoid, asparaginase, what was the required dose, what was the pharmacology, different preparations have been used, the route of administration has been investigated. The question was posed whether high-dose methotrexate is necessary as a drug that could improve the protection of the central nervous system and maybe also of the testes. Cyclophosphamide has been used, RC has been used in B-cell precursor ALL, and it could be shown that they are not really necessary. Then the radiation therapy to the central nervous system has largely been abandoned during the past years. There's almost no child anymore that gets radiation therapy to the central nervous system. Duration of therapy was asked whether it was necessary or useful to prolong the duration of therapy in boys. Mercaptopurine, thioguanine have been compared for the maintenance treatment, and there was no superiority of thioguanine. Treatment has become stratified, and then the question came up whether MRD is absolutely necessary for the treatment of acute lymphoblastic leukemia. And during the past years, one has got the impression that MRD seems to be indispensable. MRD is absolutely necessary. In Russia, we have made interesting experience with MRD. This was a publication here by Valentino Guenter, and he stated that molecular response to treatment redefines all prognostic factors. In Russia, one of the premises for the treatment trials was that we wanted to have a rational therapy, and that was also related to costs. One MRD monitoring for one patient, when you use molecular genetics, is about 2,500 euros. When you use flow cytometry, it's about 10% of this amount. And when you think about this trial with 3,000, 3,500 patients, this would cost only for the MRD 8.75 million euros, only for measurement of MRD. So this is very expensive stuff, and it was clear that would not be feasible for trials here in Russia. And the question was, is it really necessary? And we did this analysis here, where we used only clinical parameters to stratify the patients. And you see, this is for comparison the publication by Valentino. Each trial had more than 3,000 patients. You see here the SR group determined by MRD, 42% of the total. Here the SR group, 49% of the total, and the results are very similar. Here 86%, here in this group SR, event-free survival 92%. 88%, 92%. Here, the intermediate risk group, 51% of the total, 42% of the total, 81%, and here in this group, 76%. And then the high risk group, also very similar. Here, 5.9% of the total, here 8.6% of the total. So these curves are very similar, and you see that this stratification was made completely without any MRD. So the question is really, do you need MRD for everybody for frontline treatment? For the relapse treatment, it's a different issue, probably. Then where we are is now, whether you look at the curves of the BFM group here in Germany, we have meanwhile reached about 90%, and this is also true for the trials in the US. And you have just seen that also in Asia, there are groups that achieve a 90% event-free survival or overall survival. Overall survival is more overall survival than event-free survival in Asia. So the present is we have reached about 90% overall survival in childhood ALL from a seemingly incurable disease. And these results, and this is very interesting, have been obtained with old drugs. This is a very unselective chemotherapy. We don't have any new licensed drugs that have been used or have contributed to these remarkable results. And so there was really no major impact of these new drugs. What is the future? What might be the future? Why do we need these new approaches? We are looking for more selective therapies. We are looking for targeted therapies. We want to overcome the resistance. Maybe we can enhance effects of multi-agent chemotherapy by additional drugs. And we want, of course, to reduce acute side effects and late sequelae. And remember the SIOP's mission, no child should die from cancer anymore in the future. So we want, of course, to cure the remaining 10%. 90% is nice, but it's not enough. What can we do? It has been shown, for instance, that small molecules, imatinib, has contributed to improve the prognosis of children with Philadelphia-positive acute lymphoblastic leukemia. And there have been other targetable kinase-activating lesions being found in Philadelphia, so-called Philadelphia-like acute lymphoblastic leukemia. And these are candidates for these tyrosine kinase inhibitors. This is also a new direction of therapy where we try to use it to introduce small molecules in the treatment. And the potential molecular targets for the treatment of childhood ALL are shown here. We have the tyrosine kinase inhibitors, we have the receptor tyrosine kinases, cytokine receptors, JAK receptors, the histone deacetylase inhibitors, then DNA methylation inhibitors, aurora kinase inhibitors, proteasome inhibitors have been used and are being used, mTOR inhibitors, and ACT inhibitors. So there are targets, molecular targets, that can be used as targets for more selected therapy. And then, of course, we have also antigens which are presented during the B-cell differentiation, which can be targeted for immune therapy. We have the unconjugated immune therapies, for instance, rituximab, and then we have unconjugated or conjugated to immune toxins. We have the bispecific antibodies, the blinatumomab, for instance, and we have here also unconjugated ibratuximab or conjugated to calciamycin with inotuzumab ozogamycin. So there are immune therapy approaches for the future. This is shown again in a compilation: unconjugated immune conjugates, polyspecific antibodies, and then a very exciting development has been the construction of these CAR T cells, which is a living vaccine with a living drug, so to speak. It's adoptive T cell transfer specific from the patient himself. Then checkpoint inhibitors are not well investigated so far, but they may also contribute to the armament of treatment of tryptophan. So a short summary: about 50 years. It has been a history of success. And survival has now reached or exceeds even 90%. Novel therapeutic are nevertheless required and aim at reducing the acute and late toxicity and hence the cure rate. And the promising candidates are currently immune therapies, small molecules, and maybe also combinations of these. Thanks for listening.
Any questions? Yes.
No questions.
There's one young lady has a question.
So, thank you, Hito, for excellent presentation as usual. I have a question. Maybe it's not only a simple question, but this is some thoughts. You calculated the money for MRD, and this is really very expensive procedures. But in developed countries, we have 90% of survival, including also those who survived after relapses. This is the overall survival. And in low-income countries, usually, no, medium-income countries, it is about 70% of survival in medium. Also, overall survival. And what do you think? We also put a lot of money to molecular diagnostic tools about to separate children for the risk factors. And molecular markers such as FLT3 mutations and are also very important for the outcome of lymphoblastic leukemia. What do you think? What is the best way for low-income countries and medium-income countries to put the money for the diagnostic tools and to separate kids for the simple treatment or very intensive treatment, including bone marrow transplantation in the first line and with BCP leukemia and so on, or to put this money to infection control and to decrease the number of toxic deaths in the beginning due to hemorrhage and due to infections? What do you think? What is your opinion? Because this is also a lot of money.
I think the most important issue for everywhere in the world, and is particular also for countries with limited resources, is education. You need training. What we have seen, for instance, in the trials in Russia, and you know that probably, is that we have clinics in which children can be very successfully treated. And we reach, even here in Russia, an overall survival of 90% with a relatively simple treatment without using cyclophosphamide. Sasha will show that in a minute. So I think we don't need this intensive treatment for everybody. And when you use intensive treatment, then you have to be sure that you have all necessary supplementary therapies available. If you don't have the infrastructure, then you will not be able to use these intensive treatments properly. You will have a diluted therapy, and so this does not make sense. Diagnostics, of course, is important, but as you see here in this example with the MRD, you can easily separate patients without using MRD, and this makes therapy much cheaper. So I think there's a combination of issues that have to be kept in mind when you design therapy for not only low-income countries, but of course, especially in low-income countries, because if you have low incomes, then you should really focus your expenses on important issues and not waste your money for things that are not necessary. I don't know whether this answers your question.
Okay, so thank you very much.